Welcome to Module 1 or Week 1, which includes the concept of elimination. At this time, I'm going to go ahead and start talking about the concept of elimination and what it includes and what it should mean to you in regards to the nursing care that you will be providing to your patient. I always like to open up what the concepts mean to you. So think about what elimination means to you. Obviously, we have a definition here that talks about how your body wastes or rids of waste. And we're going to be thinking about a couple of systems in particular that talk about elimination of waste product. Um, Respiratory definitely releases products, i.e., the CO or the carbon dioxide, um, and the skin with the excretion of fluids when you're sweating and things like that. That is also a way to release waste from the body. But in particular, we're going to be talking about the GI and GU system. We will focus on three major categories in regards to what this concept means to us in regards to what complications might be able to arise out of these systems if they are not functioning correctly. Three main categories include your control, your retention, and your discomfort. When I think about control, I think about the generalized term of incontinence. Incontinence is probably one of the major things that you're going to come across in taking care of patients, especially your geriatric patients. You've probably seen it before when you were at the nursing home. You've probably seen it last quarter when you were at the hospital at RMH and on floors like 3 East. In particular, that carries a heavy geriatric population, you may very well see incontinence throughout all your patient load. When I think about control, I think about incontinence. There are a few pieces of incontinence that you can think about, which include stress incontinence, like when you cough or laugh, you unfortunately might have an accident. You have your reflex incontinence, which has to do with how your bladder is contracting, and unfortunately, it does have passage of fluids through, which cause an accident. And you also have your urgent incontinence, which is that urgency to go to the bathroom, which unfortunately you can't wait and you end up having an accident. Control to me in regards to the GI sense has to do with diarrhea. That's the first thing that comes to my mind. Diarrhea. Unfortunately, people may not have the ability to make it to and from the restroom in a timely manner. They may be on certain medications that's causing the diarrhea as well. So sometimes they do lose a sense of control. In regards to retention, I think about retention of urine. That's a big reason why individuals end up with a Foley catheter because they are retaining so much urine, causing discomfort in their body, causing fluid overload in their body, and we do have to release that so that we can then intervene with those issues that they're currently having. Um, on the GI side, I think about constipation. Um, I truly don't believe, even though I have heard some patients tell me, I truly don't believe that you can go more than 5 days without having a bowel movement. The readings that I've done, you can carry upwards of 40 pounds of waste in your stomach. And obviously, with our assessment piece, that would include abdominal distension, that would include tenderness, firmness of our bellies, if any of that was still on our stomach. So when patients tell me that I usually don't go for several days, that's just really hard to believe because the more you eat, it's not going anywhere. So you can't tell me that you're uncomfortable and not saying that you do have constipation. In regards to discomfort, you might as well go ahead and connect that back to the control and the retention categories because obviously you're going to be uncomfortable if you're urinating all the time. And you're going to also be uncomfortable if you're having constipation or urinary retention. I do think about a gentleman that I had, it was a long time ago. He was in the hospital. I don't remember the reason. And when I came on shift, the nurse had told me that he's been having abdominal pain. So what they've been doing intervention wise was giving him Dilaudid. So in my eyes, there's always a reason for something. So with the physical assessment that was done, Clearly, he had abdominal distension. Clearly, he had tenderness and firmness to his belly. But one thing I'm not sure that was not recognized was that he had not urinated for several hours. Lo and behold, we did a bladder scan on this gentleman, and he had well over 999 milliliters in his stomach. We put in a Foley catheter. Over time, we got out about 1,200 milliliters of urine. Did he continue to need that dilaudid? Absolutely not. So that's again why your assessments do mean something in regards to how the interventions are going to play into aiding your patient's needs. I'm not saying that it was truly missed by everyone who was giving him Dilaudid, but clearly abdominal pain, you can have abdominal pain for multiple reasons. We just need to make sure that we're addressing what needs to be addressed at that time. Thinking about some exemplars or conditions that have to do with elimination. At this time, I just want you to go ahead and take a minute or so and think about conditions that you have been made aware of, maybe patients you've taken care of, and then we'll come back and I'll kind of give you a little bit of my exemplars that I think will be nice and fitting into this. Okay, so what did you think about? Right off the bat, I mentioned diarrhea, I mentioned constipation, um, just going back to your PowerPoints, there were several conditions that were highlighted. For instance, cystitis or urinary tract infection, and BPH or benign prostate hypertrophy, which is what our gentlemen sometimes have to deal with. On the GI side, gastritis, ulcerative colitis, Crohn's disease, stomach cancer, colon cancer, bladder cancer, kidney stones as well. These can all be listed as exemplars of the elimination concept. Your PowerPoint does a pretty good job in regards to pointing out the direction you need to take it in investigating from an assessment piece to the intervention piece. Just going back to kidney stones in itself, just think about it. If you're thinking about the anatomy of the kidneys are up top, and then you have two tubes leading down to your bladder. Those two tubes are your ureters. Your ureters are extremely narrowed. So just think about a stone trying to pass through those ureters. Clearly, with someone who has kidney stones, that's where their pain's coming from. They have pain due to the spasms of those stones trying to come on down, and just in general, they're trying to come down a tube that was not meant for stones to pass. So we've identified that there's pain. Now, how do we get those stones out? And I can tell you right now, it may seem like it might be more complex, but it really isn't. When you think about how you're going to fix the patient, pain issues, getting the kidney stone out. So honestly, the mainstay treatments for kidney stones are pretty much just pain medicine and flushing them out with IV fluids, and maybe some nausea medicine as well, because the pain's so excruciating that it's causing nausea and vomiting. But pain meds and flushing it out is probably the all-time mainstay interventions that are for kidney stone patients. Our hopes is always that a patient does end up passing a stone, because then we may very well be able to send that down to a lab, identify what substances are in place in that kidney stone, and have some patient education directed behind that. Calcium is probably the most common substance found in kidney stones. So maybe someone was just taking a lot of supplements and taking a lot of calcium, and unfortunately things like this happened. In regards to cystitis or E. coli, I did read in your PowerPoints how 90% of those with the UTI, unfortunately, it comes from E. coli. The way I can kind of think of that is especially how people wipe. More than often, our stools might actually have E. coli in it, and that's just an introduction if you're not wiping correctly. We also worry about catheter associated UTIs as well, so that's why it is so pertinent on maintaining that sterile technique when you are inserting. In regards to the anatomy of the urinary and GI system. You have two videos here that you can go ahead and click on at your leisure, just so you can kind of get a refresher on what the systems are looking like and why things might make a little bit more sense when you see that the ureters don't have any space for kidneys and whatnot. So please take time to do that. So assessment. Assessment means everything because your clinical findings are going to be pertinent to what care is delivered. You just can't make something up and tell a physician that and this is happening, because then you end up with false interventions that have nothing to do with why your patient's there. So that's why your assessments mean a lot. Um, I always ask, when was the last bowel movement? That's one thing I ask at bedside report or during my initial physical assessment. When was your last bowel movement? That is important to know, um, especially for those who are in there for more complex situations, are in there for maybe a trauma and they're taking a lot of pain meds. Obviously, we don't want to do them any harm. So we do have to make sure we're monitoring that. Um, in regards to diet, are they not eating enough fiber in their diet? Are they eating too much fatty foods? What might be contributing nutrition-wise as to why there might be a change in bowel habits? Again, this is questions are questions that you should be asking during your assessment piece, because obviously, again, we want to build our subjective and objective data at this time. New medications. Good question to ask, especially if it has to do with narcotics. We usually pin narcotics as being a contributing factor to constipation, but there is research out that narcotics can definitely hinder or actually cause urinary retention. So you want to be mindful of that as well. And if a patient is on maybe something called Flomax or Terazosin, those are medications for prostate issues. So even before you knew that they had a health history of prostate issues, those medicines can possibly tell you a few things. But one thing I want you to keep in mind is the indications for medicines. Indications for medicines does not always have to be what the patient's in there for, what they might have been having condition-wise in the past. Terazosin, which is a medication for prostate, you need to be careful with that one because that one can actually cause a reduction in blood pressure. I do remember a patient that another nurse had, just kept having low blood pressures, and we couldn't figure out why until I looked at her medication list, and lo and behold, she was on a medication called Terazosin. I wasn't terribly familiar with it, so what I usually do with meds like that, I always go to their side effects, look and see what might occur if this medication is taking, and lo and behold, in the cardiovascular section, Terazosin, which is used for benign prostate hypertrophy, is also used for to lower blood pressure. So you do want to be mindful about indications and side effects, definitely. And alterations in elimination, good to know if that person has nocturia or dysuria. Um, Nocturia could be something pretty serious, like heart failure or something like that. So it is good to know if they're having issues with getting up and about throughout the day or throughout the night, because they have to use the bathroom. In regards to patients with prostate issues, we need to ask that male, are they having any urgency, frequency, any weak stream of urine when they're urinating. Those are definitely things that we should be asking the patient if we're suspecting certain things. In regards to examination techniques, you can talk about inspection, auscultation, palpation, and percussion. Um, when we talk about the GI system, we usually think stomach and colon, but you got to remember you're thinking about all the other organs that might be involved in the GI system. And don't forget the liver. We can definitely percuss the liver. There might be something going on with the liver that might be causing an alteration in bowel movements. Palpation, obviously, for tenderness, location, size. Auscultation, listening to all four bowel sounds or bowel areas. And when you're listening to the quadrants, whether they're hypo, hyper, or absent. Just remember that key piece of absent vowel sounds. You do need to listen for 5 minutes to make sure you're absolutely hearing nothing. Um, Next up, we will talk about diagnostic test, and at this time, I will end part one of the video.